Should I begin, Sally?
I think you could. We have a good amount of people here right now, so absolutely.
Great. Well, thank you everyone for joining. I know last time we had patients from all over the world join, so it's good to hear that people are interested. I'll try to go over one of my favorite topics, that's the sore thumb. And as we start, feel free to type any questions you have into the chat, and Sally can read those questions at the end. There's also the raise your hand function, which we can try to utilize if there's something in the heated moment you want to ask. Also, I ask you to try to keep your questions a little general and not too specific so that I can hopefully give you a good answer. And I'll try to do a talk every month or so. So feel free to let me know if there's any topics that you're interested in. A little bit about me. I did my undergraduate at Penn State University. I'm from Philadelphia. Got my medical degree at University of Illinois in Chicago. I did my residency where they're filming the TV show The Pit, and I haven't seen it. So if any of you in the audience have seen it, I've gotten many messages that I should check it out. I then did a traveling fellowship in Zurich, Switzerland, and I did my hand and upper extremity fellowship in Philadelphia as well. If you're interested in any of the research I've done, you can go to pubmed.gov and type in my name with my last or with my first initial. So the sore thumb, I'll try to distill kind of the 16 years of training that I've done into helping make some layman examples of what's going on with the sore thumb. The origin was literally in the 1800s, where just the bandage of a sore thumb just really sticks out because that's kind of what makes us human, is the opposable thumb. So we'll talk about the symptoms of the sore thumb. We'll talk about the description, mainly arthritis, but we'll also go over de Quervain, which is mommy thumb, and because it's winter, we'll talk about skier's thumb. There's also numerous other thumb pathology that we could talk about, and maybe I'll try to do that a different day. But these are kind of cover the three biggest ones that I've seen in my clinic the last several months. We'll go over the pathology of how those three injuries happen. We'll go over the treatment options, both non-surgical and surgical, and then we'll have some time for questions at the end. So as an overview, this is a picture of the hand. The thumb is over here, and this is mainly what we'll be looking at today. And the small finger is over here. So you can see on the thumb, there's three bones. Now, these are the two that you will see mainly on your hand. And then this is the one that goes as the finger joint, or the finger of the thumb. And this bone is actually within the hand here. So this is called your distal phalanx, or your distal phalange, your proximal phalange of your thumb. So distal away, proximal close, and then your thumb metacarpal. You also have extensive anatomy that we could go over for weeks, but essentially you also have innervation, which causes sensation and muscle control. So on the back of your hand here, you have two nerves, these white little structures. This is from the radial nerve. And then on the volar side, meaning the palm side, you have innervation from your median nerve. So the thumb is dually innervated as far as sensation goes. If we're really getting down to the nitty-gritty of the muscles, you have four extrinsic muscles, meaning the muscle bellies are actually in your forearm, and they pull on little strings. So for example, this would be one string. This is another string right here, and then this is a third string. So you have four extrinsic muscles, and meaning you have one on the bottom side as well called your flexor, and that's where the muscle belly is in the forearm and the tendon goes to the actual digit. You have four intrinsic muscles. That is where the actual muscle belly is in the hand, and it pulls on the thumb. So one of the most common things that I see in my clinic is the painful thumb, the sore thumb. And one of the most common causes of that is arthritis. So what the heck is arthritis? And it's also very confusing too, because there are many kinds of arthritis. And so for a patient, this can become very confusing. We're going to focus today's talk on osteoarthritis, which is the normal wearing and tearing of the joint. However, there are many other types of arthritis as well. There's rheumatoid arthritis, which is an inflammatory disease, along with psoriatic arthritis, ankylosing spondylitis, gout, which can be either people can be predisposed to that, or diet and exercise and drinking can lead to those things. There's also lupus, and then there's septic arthritis, which would be an infection. So I like this picture on the top here, because if we're thinking about two bones, and we'll see in the x-rays later, the bones don't actually touch each other. There's a nice space in between them. And that space in between is cartilage. Anytime a bone touches another bone, there's a cartilage cap on it so that it prevents the bones from touching one another. Typically around the joint, we have a capsule here, which would be outlined in purple, and it fills in that area and provides a wrapping so that we can provide a fluid in there to make it nice and lubricated, so a slick surface. So it's a very low friction environment. And then the muscles can pull on bones from different directions, causing them to move. So this picture on the bottom would be a normal joint. You have two bones and you have a cartilage cap on both sides. And then this would be in a joint affected by osteoarthritis. For whatever reason, something happened, either normal wearing and tearing, a trauma, or the alignment was off. And we'll talk about that in a little bit. And that can cause disruption of the cartilage, eventually to a point that the bones touch each other. And when the bones touch each other, I like to liken this analogy to a car. Cars don't actually touch the road. The tires touch the road. And so if the car actually gets to a point where the tires are gone and the car touches the road, then you can produce sparks. And those sparks is the inflammatory cascade that causes pain. So throughout this analogy, as we're talking about osteoarthritis, which is normal wearing and tearing, we're going to use this analogy of tires on the car. So specifically, when we talk about the thumb, patients will come in and point to exactly this area, or maybe even a couple of different areas of where it hurts. They might even point to the palm side of their thumb of where it specifically hurts. They might say that it's aching, it's dull, it's throbbing. And if we take a look at the thumb with x-ray, we can take a look inside of the thumb to help us take a look at what osteoarthritis looks like. And so if you remember my analogy earlier where I said bones don't touch each other, you can see here we have two distinct bones with a black line in between. The black line is in air. The bones aren't floating in space. There's cartilage in between those two bones. So for example, in this picture here, we see a nice healthy cartilage surface. That slick environment, that low friction environment where the joint can move freely. So then what does osteoarthritis look like? Well, years and years of research have helped us come up with this classification, the Eaton-Littler classification. These are two famous hand surgeons from New York. And you can see as the classification goes up, the space between these two bones specifically gets smaller and smaller and smaller. And even on this one, this bone is almost dislocating out. You notice bone cystic changes here. You notice big bone spur formation. And you even notice some osteoarthritis, meaning narrowing of the joint space over here too. It's affecting another joint. And so we'll go through each of these classifications. So stage one, they classify as, and again, on the upper right-hand corner here, I kind of have a red box of where we're zooming in on the x-ray so you can keep in perspective of where we are on the hand. But stage one of the Eaton-Littler classification is slight joint space widening, and that's because you have a little bit of inflammation going on, pre-arthritis. So if you think of a tire that's almost going bald, it is it's more inflated right before it's about to explode. And so this tire is a good example of stage one, where the tire looks a little more inflated than maybe the previous tire that had full tread on it. And specifically, the joint space they're talking about is right here. This is called your carpal metacarpal joint space. This is the carpal bone. Remember, we said the distal phalangeal, the proximal phalangeal, and the metacarpal, and then the carpus. Stage two, we see slight narrowing of the joint. So after it's widened a little bit, we'll see narrowing, and you also see small bone spur formation. So you can see that this space here is narrowed. We see hyper white in this area, which is what we call sclerosis. We see little bone spurs over in that area growing, and even a tall one here. If you really look close and you see the consistency of this bone looks pretty symmetrical in this area, but then you look over here and you see little dark spots with hypergenicity around it, that is cystic changes formation. So that's the bone is actually remodeling to the changes that are happening. Well, this would be similar and analogous to driving on a flat tire. That you're able to do it, but the car isn't going that well, you don't have good grip on the road, and you can't go that fast. That would be very similar. Now, stage three, you have marked narrowing of the CMC joint with sclerosis and bone spurs greater than 2 millimeters. So we can almost not even tell that these are two different bones right here. We see a big cyst right here, a cyst here. We see 3 little cysts here in this area. You see the hypergenicity, and you even see this big bone spur growing on the volar aspect here. This would be like driving on a road on a tire where the wheel has actually been ripped off, and the rim is actually touching the road. Then we get to stage 4. Stage 4 is when you have trapezial arthritis. That's where you actually get involvement of the other joint here. So this joint has worn out so much that it actually could involve the SDT joint. You see big, giant bone spurs here. You see the hypergenicity of the bone remodeling. The thumb is trying to dislocate out. You see a big bone spur growing volarly. You also can have changes that you might notice on your own hand of what this would look like. So for example, they call it MCP, or they call it metacarpal flexion with MCP hyperextension here. And this is where you see this bone popping out. So the base of the thumb is popping out, causing this to bend down, and then your thumb counteracts by extending at this joint. Well, this is the equivalent of literally driving on the rims to the point that your fender is dragging on the road. It's affecting the back tires now, and you're even driving on your side rail here. This can be very painful, or I've even seen this in patients where it's not painful at all. It just depends. And this is where, when a patient comes to my office, the biggest thing we talk about is what their symptoms are, what bring them there. I don't generally treat x-rays. I generally treat the patient and what the patient is going through and what the patient is experiencing. So that helps us formulate a plan. So specifically, if we're talking about CMC arthritis, I like to kind of put everything into 3 buckets for patients. You have 3 different options. The first option I always say is do nothing. That you were doing nothing beforehand, there's nothing to say you can't do nothing into the future. That's always an option. It's not cancer, it's not going to kill you, it's normal wearing and tearing. It's the unfortunate part of aging. A second option that I like to bucket this into is non-surgical. What can we do without surgery that can try to make your symptoms better, that can try to help you cope with it, that can try to help you prevent you having from those aches and pains towards the end of the day? The first bucket that we can talk about is within non-surgical is medications. Now, I'm not a believer in putting people on medications for the rest of their life. In fact, I try to limit the medications. But I think in this case, it is worth trying. So generally what I'll do is I'll talk to patients and I'll say, let's trial a strong NSAID for a month. Take it on a regimen where you take it every 8 hours or every 12 hours. And that works more as an anti-inflammatory effect than if you take it once every 5 days because you have pain. That works more for pain control. So I usually say, let's try an episode of non-steroidal anti-inflammatories for about 30 days on a regimen and see what happens. If it works, great, we can talk about continuing it. And if it doesn't work, we tried it and we rolled something out. Some patients also really like Voltaren gel. That's a topical gel that you can put on the skin there. Now, Voltaren gel you can get over the counter. There's also a prescription grade that's a little bit stronger, and so that's always a good option too. Sometimes people respond to different things. There's good therapy that can be done. Therapy can show you different ways of doing things, different ways of grabbing things and holding things, and that can be a very useful aspect. Bracing. I'm a big fan of bracing. And I don't mean to wear these braces when you're going out and you're dressed all fancy and you're going to a company dinner or a company holiday party or something like that. I mean to wear a brace when you're doing the activities that really bother you the next day. So if you're shoveling snow because it's the winter right now, or you're raking leaves in the summer, or you like to garden, those are good times to wear a brace where you get a little extra support. And what that support does is it prevents the bones from rubbing each other because the thumb isn't moving as much. And people always ask me, hey, doc, what's the best brace? And I always say the best brace is the one you're going to wear. So if you think that this one's the most comfortable one, wear this one. If you like this one up top, wear that one. Whichever one you think you can wear that will give you a little extra support, I'm all for. There are 2 types of injections you might hear about. The first is a corticosteroid injection. That's basically putting a high potency anti-inflammatory in that joint space to try and calm the symptoms down. Now that injection isn't going to build new cartilage and recreate the tires in the car. But if that injection can treat your symptoms enough such that you can live your day-to-day life without pain and discomfort, then I'm all for trying that as well. Sometimes patients will say they work 6 months, sometimes they'll say they work 3 years, and other times patients say they don't work at all. It really depends, and sometimes patients need more than one injection. Another injection you might have heard of all over the radio is called a platelet-rich plasma, or a PRP injection, and studies really haven't shown too much that this can be that effective. Now, a lot of times insurance does not pay for a platelet-rich plasma injection, so therefore I have a hard time looking some of my patients in the face and saying that that you should go out of pocket for a platelet-rich plasma injection. If money isn't necessarily an object for you, it's certainly something that you can try and see if it works for you. As far as testing, we went over the x-rays that really help us diagnose what's going on. The last bucket that we'll talk about is surgical intervention. So we talked about doing nothing, we talked about non-surgical, and now surgery. I typically will offer patients two different types of procedures, and they are very different procedures with very different coaching going into it. The first surgery that we can talk about is a denervation. And as we showed in the very beginning, there are nerves that go into the hand and specifically into the thumb. Now, this procedure has been popularized within the last 5 to 10 years. And what you do is you make a small incision on the back of the hand, and you go in and you cut the tiny little nerves that are going to that joint. So when those bones are rubbing against each other, the nerve can't send the signal back to the brain saying, hey, I'm really hurting. The theory works very well. And if you listen to the people who kind of founded this procedure, they'll tell you that it works very well too. From my experience, it's generally the pros of this procedure are because we're just making a very small incision and we're cutting a couple of small nerves. It's a very quick recovery. It's like a 2 to 4 week recovery until you're feeling almost full speed. It also does not prevent you from having the next procedure that we're about to talk about. The downside of this procedure is that I've seen anywhere from no relief to 100% relief, meaning I can't adequately guide you on how great this is going, great or not great, this is going to work for you specifically. But it is a very good option. It's minimally invasive, and it only takes a short amount of time, and that is a very quick recovery. The second procedure that we talk about is arthroplasty, and there's many different techniques. Probably if there's 500 different hand physicians in the Colorado area, they probably do it 200 different ways. But basically, what you do is you take out when we showed earlier, the two bones that are rubbing, you take out this bone right here, so it can't rub against this one anymore, and you fill this area with scar tissue. Now, it's a little more technical than that, obviously, but the good news is they all kind of roughly do a similar thing, and that's removing this bone and filling this area with a scar tissue. The pros are that you can reliably, and the studies show this with just about any technique, relieve about 95% of the pain. So I can pretty reliably get rid of 90% of the pain in the base of the thumb. Now, the downside is it's a 3-month recovery, and generally most patients do not like it before they really like it. So it's a very serious thing to consider. Now, we did talk about mainly the arthritis at the base of the thumb here, but it's also very possible that you get arthritis here, what we call the IP joint, or excuse me, the IP joint and the MP joint here. There are similar treatment options for both of these, which we can discuss later, but these are much less common. The most common place is a dull, aching, throbbing at the base of the hand on the radial side of the hand. Now, the second most common thing that I'll see regarding base of thumb pain is called de Quervain's tenosynovitis, or mommy thumb. And this is basically the thumb side of the wrist. It's right at the base of the thumb here. And it is commonly confused with arthritis, but we're going to give you some tips to look out for. Typically, this is revolved with a repetitive activity, such as lifting a baby. And you can see as this woman here raises this child, you can see the tension that is pushed on these two tendons that go into the hand. And basically what that is inflammation of those tendons, and we'll talk about why that happens. So the most common people I'll see are people that are lifting a baby, and that doesn't just mean mothers, it could mean grandmothers or aunts or uncles, or even daycare providers. I see with people that are doing repetitive activities such as cleaning. I even had a patient that I just operated on the other day who had this because he played curling so much. I also see this with people that write a lot, and sometimes people use a keyboard and a mouse. So if you think of the back of the hand, this is cutting the hand in an axial view. You have these 6 dorsal compartments here that each of the tendons reliably go through. De Quervain's is inflammation and aggravation of the tendons that go through the first compartment, which is right over here. And if we look at a different picture here, you can see when they give the thumbs up, so that's the same position that if you're picking up a baby, you're kind of in that thumbs up position. These tendons here are really on stretch over here. And why these tendons are on stretch is because they go through a tunnel. Because if these tendons were smart, they would make a triangle out of this. but they can't do that. So they have to follow along here and go up there. So that puts a lot of tension and a lot of pressure on those tendons. They didn't follow the geometry classes 7th grade. If we really want to get technical, there's variations of these tendons going through the tunnel. Sometimes they're within the same tunnel. Sometimes they have 2 different tunnels. Sometimes it's a partial tunnel, or sometimes there's even just one tendon. Most of the time when I see de Quervain's tenosynovitis, I see that the tendons are in 2 separate tunnels, and the EPB specifically is in its own tunnel that is a little too tight. Usually they call it a subtunnel, and it's a tunnel within a tunnel is usually the problem. So here's a good example of a person extending all their fingers, giving their thumbs up, and you can really see the tension that's on the back of their thumb, the tendons there. So again, what are the treatment options? Specifically for mommy thumb, usually because, or de Quervain's, it's usually because of an activity. So sometimes if you can do nothing and just modify the activities that you're doing, it should resolve over time. So typically rest, ice, compression, elevation, and that'll generally help the symptoms resolve over time. But it's also hard to tell a mother who has a brand new newborn, or tell the newborn who's 3 months old that, hey, mommy needs to take a break for a little bit and can't pick you up for a while. So what are some non-surgical options that we can do? And you'll see a theme here. Again, we can try the non-steroidal anti-inflammatories of Voltaren because it is an inflammatory process. We can try therapy. It's really good for helping you work with activity modifications, different ways of using your hands to do the things that you do for work. We can do a similar type of bracing where we do the thumb spica splint, and what that does is that prevents a lot of the tension on the thumb. This is one where injections work exceptionally well, particularly the steroid injection. It's very easy landmark to see. If we look at the previous slide, these are very easy landmarks to see, and I can reliably put an injection right inside that tunnel in order to get the anti-inflammatory right there. Testing, we do x-rays. You can also sometimes palpate a cyst in that area, and x-rays can sometimes help you pick up a cyst. Now, why would a cyst be problematic? Because if you think of the size of a tunnel, and all of a sudden I put a cyst inside of this tunnel, there's less volume in there. So if there's less volume, that means those tendons are rubbing against even tighter spaces, and that can be really irritating. For surgical treatment, there is similar to before in that there is a small incision that you can make on the radial side of the hand, and you just pull the radial sensory nerve out of the way, and then you can see this thick tunnel, and you just open up the tunnel right here. Then I can see the tendons, and I can go up and down the tendons and make sure they're not entrapped anymore. The whole procedure will take about 20 to 30 minutes, and we also would take out any cyst or mass that was there at the same time. Pretty reliably, it resolves the pain. Now, the pain might take a couple of weeks to resolve because the tendon is so irritated, but generally patients really like this procedure. So because it's winter, we'll talk about skier's thumb in Colorado, but if you were from Scotland, they would call it gamekeeper's thumb. And this was diagnosed in the 1940s as the physician there noticed that a lot of the Scotsmen from the woods who would herd and trap smaller animals, that they particularly got this laxity at the base of their thumb, where if they were pressing really hard on their thumb got weak here and it could open up on the side. And we'll talk a little bit more. Here we see it by people holding a ski pole, which a sudden stop of the ski pole causes the thumb to have a tendinous injury. So if we think of this as the hand, this is the collateral ligament, ulnar collateral ligament that we're talking about with skier's thumb. And what happens is a hyper abduction force causes the thumb to move this way, while the rest of the hand stays the same, causing a lot of stress on this tendon and tearing the tendon. And this is a good representation of that. Something pulls the thumb this way and tears there. Now for skier's thumb or gamekeeper's thumb, you can see a couple of different ways. There's a bony option, and that's where instead of the tendon, instead of the ligament pulling off, which would be, it takes the bone with it. So the actual tendon is still attached to this bony fragment, and so that one you could just reattach the bony fragment. There's also soft tissue ulnar collateral ligament injuries, and that's, you can see here, where the thumb just keeps extending side by side, and this was really painful. Now, a patient would probably never let me do this to them in the clinic because it would be so painful, but in the operating room, this is something that you can really test out. Within skier or gamekeeper's thumb, there's a couple of different variations that we have to be mindful of. And the first is called a Stener lesion. And that is what happens is the thumb gets pulled so far that when the ligament tears, this green hood or the adductor aponeurosis gets stuck in between the tendon. Why this is important is because if the tendon even tore, but the thumb is like this, the tendon can heal back to itself and you can possibly avoid a surgery. From my experience, anytime there's a Stener lesion, it requires a surgery. Otherwise, you have an unstable thumb. So there's a classification for a skier's thumb as well. The first is where it's a sprain, there's instability. So that might be where this was torn, but it's either partially torn or the rest of the stabilizers of the thumb are able to keep that bone from moving truly apart. It's just painful for 6 to 8 weeks, and we go through different treatment options for that as well. The second would be where there is asymmetric laxity, so I'm able to move one thumb a little more than the other, but there's a firm endpoint where I can't keep moving it like that x-ray we just looked at, where the thumb keeps going all the way around. And the third is where there's joint instability without an endpoint, meaning if the patient did have discomfort or didn't have pain, you could just keep moving the thumb all the way around. The other classification for the third would be if there's 15 degrees more laxity than the contralateral side. And then the fourth, which I like to put separately, is a Stener lesion. So again, treatment options, generally this is not recommended even for the grade 1. Generally, even for a grade 1, the pain, the discomfort, and the probability of upgrading to a grade 2 or grade 3 increases if you don't do any types of bracing. So generally, doing nothing is not recommended. As far as non-surgical, typically this is most patients that I see, and is mostly grades 1 to 2. Bracing is the mainstay of treatment. We can send you to our therapist to make custom splints, which they're great at doing. We can also do casting for the patients who want a little more support. This is the mainstay of treatment. I generally cast or brace people for 6 weeks. And then at 6 weeks, we take it out and we test your ligament and we make a mutual decision-making process of if you want to continue bracing or if you want to deal with a little bit of discomfort moving forward. Medications are generally for pain only. Therapy does a great job making splints. Injections, there is a small role for platelet-rich plasma in this, in that area is a soft tissue injury. And so by inciting the growth factors into that area can sometimes heal things a little faster. I would not recommend this for most patients, but in very certain situations that this is something that is reasonable. I also further usually get MRIs for these. If there's any question of asymmetric laxity, no firm endpoint, or hypersensitivity to pain, I generally will get an MRI to investigate further. So as far as surgical, this is generally type 2 or type 3. So generally, if it's type 3, it's fairly easy that there's no endpoint, the thumb would keep going. You can imagine how that would be really uncomfortable and really debilitating. But there's also a scenario that maybe a very elderly patient might not want any type of surgery, and then they might just like to do splinting. Grade 2 is what Drew Brees had famously a couple years ago, and that's typically treated with surgery. What we do is we take an internal graft and we recreate the ligament, and what we do is we do what we call an internal brace. That's where we put a fiber wire tape on top of it to give it some augmentation while the natural tendon or the ligament is healing. And so since we were just talking about football, and since I'm from Philadelphia, congratulations to the world champion Philadelphia Eagles, second time. I'm sure everyone on this call is happy that the Chiefs were not standing on the podium again. But I'm sure everyone was hesitantly rooting for the Philadelphia Eagles. So with that, thank you very much for your time. We ended right at 30 minutes, and I'm happy to answer any questions.
All right, great. We have several questions. Right. The first one is from Julie, and she says, I can't take NSAIDs. Are there other meds or supplements to reduce inflammation?
Yeah, there's a list of supplements that have been reported to reduce the inflammation. There are also some NSAIDs that are much lighter on the stomach and kidneys than others. In these types of situations, I would refer you to your primary care physician or a nephrologist perhaps, and see what we can come up with in a mutual decision-making process of what would work on your specific case. But absolutely, I think the goal is decreasing the inflammation. So there are certain diets that can help, there are vitamins that can help, those kinds of things.
And then Chad would like to know, what are your thoughts on shockwave therapy?
It's a good question, Chad. I'm not specific I'll be frank, I'm not up on any literature that talks about shockwave therapy for the CMC joint or thumb arthritis specifically. So I'd have to look something like that up and get back to you.
Great. Lynn would like to know, does the Quervain process create numbness? Oh, sorry, the denervation process create numbness or lack of function or sensation?
It's a good question, and I'll go back to this slide. So depending on which paper you read, there are 4 or 5 nerves that go directly to that joint. The goal of the surgery is not to do anything that would disrupt your sensation on your hand. It's only to disrupt the branches that specifically go to the articular joint and the articular surface. So when done properly, you should not lose any function, and you should not lose any sensation on your actual hand. Now, with that said, anytime there's a surgery, you're at risk of having scar tissue and possibly losing some range of motion of your thumb. So I want to make sure I caveat that for you.
Perfect. Randy wants to know, does removal of the bone in the arthroplasty procedure impact the use of the thumb? And can you also describe what activity, if any, is allowed during the 3-month recovery period?
Yeah. So removing that bone, generally, as you can see in some of the previous imaging, let's see. Some of the patients come in with a pretty big deformity of their thumb. So it's hard exactly for me to give you a straight answer. Generally, what I tell patients is you'll probably have about 90% of the range of motion that you had before. Now, something like this, I'll probably make your range of motion different because I don't think the tip of this thumb could touch over here, which helps you really grab something. So in that case, I would redo the thumb to more of an angle like this, the natural position of your thumb if you look at your hand, which helps you grab things a little better. But in general, I tell patients you'll have about 90% of the range of motion that you had before with 95% less pain. That's generally what I tell patients. And Sally, I'll turn the therapy on to you, since you're a head therapist, of what would you recommend for the patients after they've had the CMC arthroplasty?
Yeah, generally, for the first 2 weeks, you're really not using your thumb. After that, we're putting you in a splint and you can do really light activities. So you could help to brush your teeth, help to put on your, like button your shirts, those kinds of light activities. And that's going to last until around 6 weeks. And then we're going to start out doing things around 3 to 5 pounds of pressure and start to build your strength back up. But just know that to open a package, it really takes about 6 pounds of pressure to open a package. So you're probably not opening packages until around 8 or 9 or 10 weeks, again, depending upon where you started from or how much muscle loss you had prior to getting the actual surgery. So like that person there, you can see how much atrophy they have in their thumb, right at their thenar area. Like that muscle's really been atrophying for a while. So that person's going to take longer to get their strength back than another. Okay, the next person's question is, can cycling long distance trigger Quervains?
It's a good question. I don't know if I've seen that specifically, but I guess in theory it would depend on your hand position on your bicycle and how much pressure you're putting your wrist in this extended weight bearing kind of position where you're lifting something up like this. So it would probably depend.
Right. If one already has osteoarthritis with pain, but not bad enough for surgery yet, and shots have been ineffective, what other things can one do keep it from getting worse?
That's a good question. And I also always tell patients too, the only driver of you proceeding with the surgery is you. And that's why I always say the one option is do nothing. So if one option is do nothing, that means you don't have to have a surgery. The driver is when you're sick and tired of the pain. You've tried all these other things to try and get rid of the pain, to try and cope with your life with the discomfort. So as far as injections go, sometimes one injection doesn't work. You don't get in the right spot, or there was so much inflammation at that time. So sometimes I'm not opposed to doing another injection or multiple injections if you're getting relief out of them every couple of months. I think the bracing is, and I'm sure Sally would tell this to you too. If you know you're doing exercises today, you're going to feel that thumb pain tomorrow. So brace yourself while you're doing your exercises, or brace yourself while you're doing your activities, such as yard work, gardening, whatever it may be. If you like riding a bike, I see that too. And then also the medications, try that too. I don't think there's any in the non-surgical bucket. I don't think there's any one panacea, but I think collectively those 5 options, those 5 things can really help to modify the symptoms you're having.
Greg would like to know, have you had any success with HA injections into the synovial sac for OA?
So what he's talking about is for knees and hips, I believe. There's a component that is another type of injection that's approved for injecting into joints, and it's called hyaluronic acid. And that is basically an artificial lab recreation of the lubricant that you already have that your body naturally makes. And so in knees and hips, it has been FDA approved such that insurance companies will pay for injecting hyaluronic acid into the joint. From my experience, I have not seen or heard of anyone injecting HA into the thumb, although I was talking about it with a colleague earlier today. The problem with doing such a thing that I foresee is that if we look at this joint, this is a very small, tight joint, and I don't know how much hyaluronic acid I could fit in there. It's also so bone on bone that I don't know how much the hyaluronic acid would extend the joint. On top of all of that, HA is not approved for this, so it'd be off label, and therefore the patient would need to pay for it separately. And that can be anywhere from $150 to $500. So I have a hard time, if there aren't good studies that show good results from this stuff, I have a hard time looking the patient in the eyes and saying, hey, let's try it. Now, on the other hand, if money isn't an option for the patient, sure, we could maybe try something like that. But we wouldn't be doing it based off an evidence-based approaches, which is how I like to do things.
Right. Susan would like to know, is the arthroplasty usually successful and is the problem permanently fixed, or is there a loss of function? And follow up to that, is the surgery only done when at stage 4?
So to answer the last question first, it's not always done at stage 4. It's whenever the patient has had enough discomfort. I can take x-rays or MRIs of anywhere on the body and find something that's wrong. But I like to do surgery when the symptoms correlate with the imaging. So I've done surgery on patients with grade 3, which is not uncommon, or grade 4. And in fact, I even routinely take x-rays of patients that come in for different complaints, and I see this look at an x-ray and they're like, nope, doesn't bother me at all. So it's when a combination of the patient's symptoms match the pathology that I can reliably look the patient in the face and say that I think I can help you. So as far as loss of function, I generally tell patients, and it depends on how bad the deformity is, but I generally tell patients you're going to get about 90% of the function that you had before. And that's because, as Sally talked about with the immobilization and things like that, you'll build an inherent a little bit of scar tissue. But I can reliably tell you that you lose about 95% of the pain as well.
Kathy says, yay, Eagles, and thank you for the presentation. And Annie wants to know, periodically, my thumb contracts significantly, turning inward, and I have to pull it back into position. What are your thoughts on that?
I think what you're getting at is that it clicks into the palm. That sounds like a trigger finger, which might be a future talk that we're going to talk about. But I'd have to kind of see exactly what you're talking about to further kind of diagnose what you're getting at.
All right. What are your thoughts on red light therapy?
I am not up on the red light therapy for osteoarthritis. I would have to look into what that does a little more and what the literature supports for that for either the arthritis or the de Quervains or even the skier thumb.
How do you distinguish between OA and skier's thumb when diagnosing the problem?
So typically a skier's thumb would be a traumatic incident. It's very unlikely that somebody would just walk in and have a no inciting event skier's thumb injury. Osteoarthritis is typically in elderly patients. Osteoarthritis, you can visually see on the x-rays like we went through earlier. So we can visually see it here. There's also physical exam maneuvers that we can do called the CMC grind, where I grind these two bones together and it recreates the pain. And then I can also do things with the skier's thumb, like palpate in certain areas, or even try to open the thumb up like that.
What do you think about taking turmeric to relieve arthritis pain?
I don't think they're great. Boulder's an interesting community because they're on the cutting edge of a lot of these homeopathic type things. I think most Western medicine, it's hard to do randomized controlled trials on turmeric versus non-turmeric and how it affects osteoarthritis. There might be in vitro studies that show that it decreases inflammatory factors, and same with red light therapy and same with the shockwave therapy, those types of things. But it's hard to do randomized controlled trials on those. However, as you can see from my kind of how I believe in either de Quervain's or even the non-operative management for CMC osteoarthritis, is I'm a big believer in multi-factorial treatment. So I'm a big believer in trying different things, especially all at the same time, because if turmeric does, let's say, argument's sake, turmeric decreases inflammation by 7%, and the NSAIDs decrease it by 7, and the Voltaren decreases it by 3, and the therapy decreases by 2, pretty soon you have a nice cumulative effect of all these different things that you're trying. I don't think that turmeric in and of itself is going to fix the pathology of this process here, of the bone rubbing along the bone. But if it can help decrease the inflammation and help decrease the signal transmission back to the brain, then it's worth trying.
Right. So if a different orthopedist also talked to somebody about using a piece of a tendon taken from the arm and fitted inside the joint space, and then there's a couple different procedures. So can you talk about those different procedures and why you would use one versus another?
Yeah, I think I mentioned earlier, there's probably 60 different ways to take out this bone and fill in this gap with different scar tissue. There's all different kinds of ways. The pros and cons are, I think in my training, somebody said, if there's 60 different ways to do things, that mean there isn't one best. What that means is the surgeon probably is doing what they're comfortable with in their hands, the thing that is tried and true for them, the way that they trained and learned how to do it. Overall, though, the goal is to get the thumb in more of an extended position. So let's see, this thumb's in a flex position. So overall, the goal is to bring this bone up more like this, and that will put the other ones down, and then to offload the pressure in this area as well here. So there are many different ways to do that. And that's why surgeons will tell you many different ways. And it's good to ask them which way they do it and if you're comfortable with that or not. Sometimes physicians will take a tendon from your arm here and transfer it. Sometimes people will just sew the tendons here together. Other times they'll drill holes in the thumb and transfer a slip of a tendon through. It really depends on what they're comfortable with, what they trained with, and what it works in their hands.
What kind of anesthesia is used for arthroplasty surgery, and can a beer block be used versus a general?
Yeah, they're all different kinds. A lot of times I don't tell the anesthesiologist what I want them to do. A lot of the times it's the anesthesiologist working with the patient to go over what they want. So I think a lot of times they go for a block, which is a numbing medicine that makes them so that they can't feel the area. And then just like a sedation, so they're breathing on their own and they're actually just kind of taking a nap behind the curtain. Sometimes patients want a general anesthesia, and sometimes there might even be reasons for a general anesthesia. But typically, I try to prefer avoiding a general anesthesia, and I try to make it a mutual decision process between the patient and the anesthesiologist of what they're going to pursue.
For arthroplasty surgery, do you typically do one thumb at a time or both thumbs at the same time?
Good question. Even with smaller procedures like carpal tunnel, where you're generally back completely normal in like a week or two, I don't try to only do one arm at a time. There's always complications that can happen with surgery. There's always stiffness. Something can happen. It's a long recovery. And the last thing I would want to do is make it so that a patient can't use both hands at the same time. You always got to have at least one hand, no matter how good of a support system you have.
If you use Voltaren for OA and it works, how long can you use it?
I would keep using it until it doesn't work.
Are there some exercises for the thumb to help alleviate the pain?
Sally, do you mind if I defer to you for this one?
No, not at all. Sure. So, Peg, the problem with exercises is that we've got a degenerative process going on here, and you use your hands all day long. So, if we were just to add more exercises to you, then we're just going to contribute to the degeneration. So, what we would do is we would sit down and we would talk about what are your favorite things to do. Like, so if you love to needlepoint, we would talk about what activities do you also do that we could do a different way, like unloading the dishwasher. Nobody loves to unload the dishwasher. So we'll talk about different ways of unloading the dishwasher so we take pressure off the thumb so that you can continue to do the needle pointing. So we would tailor your day to your thumbs so that you are trying to take the pressure off the thumb and to do activities in a different way so that we're not contributing to more degeneration. Mike says, I gave myself a skier's thumb 4 weeks ago. Do I give it another 4 weeks with a brace, or would it be wiser to come to see you ASAP?
It's hard for me to give you concrete advice of what happened to your thumb because I don't know how, like, I haven't done a physical exam to tell you how damaged it is. Meaning, is there a firm endpoint? Is there laxity? And how discomfort it is. I would generally say, though, that the earlier that you are seen, if it is a complete tear, or the earlier that you find out if there is a Stenner lesion which needs surgery, then the earlier that you can move on with that and then move on with your life. So, for example, if yours is a stage 1, and here I'll pull it up right now. So if yours is, for example, a stage 1 where it's still completely stable, then you're not doing anything by continuing to bracing. That you're not wasting time on the clock. If, for example, yours is a Stenner lesion and these are actually not touching, then you've braced yourself for 4 weeks and it hasn't really done anything for you. That's a possibility. I don't really know without examining it. I wish I had a better answer for you. I'm sorry.
I can feel my lower thumb bone crunching when I move it. Pain comes and goes, and it's really random. I do yoga daily, and I work with my hands. Since I need my hands for work, what would you recommend long term? I'm 61 and I want to keep working and gardening.
Yeah, you sound so much like my patients that come in every day with this. So feeling the crunching, the bone bumping, that's exactly what this is right here. The bone's coming out. You can feel the grinding right here and it causes pain. This is such a tough problem for people because they want to be so active, especially in this community. And they want to get back to the things they want to do, and I want to help them get there. So, in regards to what you can do, I think we talked about some of the non-operative things. I would try splinting. I would try bracing. I would try the injections. Um, and if it's completely random when it happens and it's not all the time, then I would probably hold off as long as I can before I really seek a surgical intervention. I spend most of my day telling patients don't have surgery because I think there's so many non-operative things we can try and we can exhaust before we get to that point.
Okay, we have one more question so far. I just had hand x-rays by a rheumatologist and blood work, but nothing came back on the labs. The radiologist said my pain and discomfort is osteoarthritis. Should I come into you or a similar physician to look at the thumbs on x-rays and get recommendations?
Yeah, it's hard to tell exactly kind of what's going on based off that. I really empathize with radiologists because they're great at looking at pictures, but they're also just looking at a picture. And when they see a picture, for example, of this hand up here, and they don't know exactly where it hurts, so they just read the whole thing. It's really when you compare the physical exam, the words of the patient, what they're telling you, with the imaging, that you can really find out what's going on with that particular patient and make a custom plan for them.
Great. Um, what are the treatments for trigger thumb?
We'll go over that in a couple weeks, but there are lots of non-operative treatments. The best is an injection, works great. That can work up to 70 to 80%.
Wonderful. So that is the end of our questions. I did record this presentation And everybody who participated today, or even if they didn't make it, will be sent a link. And then this presentation will be on the bottom page of Dr. Hammerstedt's web page on Boulder Center. At the very bottom of his page, he has videos. So if you're interested in other talks that he has given, you can see them there as well.
Thank you, everyone.
Thank you.